Why don't we kick off today with a little recap of what happened last night? So you know, we're bringing everybody together. This is we're bringing the band back together. We'll do everybody a little roundtable intros in a second. Some of you guys probably either don't know each other or forgotten what each other look and sound like. But I'm just gonna throw down that Ryan came out here. I got a chance to meet his new wife. Congratulations. Thank
you.
And we were all at an event that was a soiree. If any of you has any of you watched $1 Million Listing Los Angeles? So Josh Flagg, the realtor, was hosting this event, which was a bit surreal. There was a Real Housewife of Beverly Hills who showed up at one point, no joke. And in the middle of it, they called for a paramedic. And Ryan, I had to go over to Ryan, who was like, you know, we'd been partaking in the event. Anyway, Ryan, I don't know if you want to jump in on that, but I was like, are you okay to help? Because they're going to need a call for someone, and you're here. Hey, Ryan, would you like
so
tell the story?
So Jonathan and a gaggle of people collected me and took me to the front of the residence where somebody had face planted and injured their left knee. Yeah, to the extent that it was the size of a large grapefruit, and ultimately requested EMS to come and transport to the hospital. And Jonathan and I were the first responders. We found out what GPCR system Beverly Hills Fire uses, and when the RFP is going out for bid.
that may not be much of an exaggeration, but I will point out, and for those of you, I think everybody at this point is connected on social. You will not see any HIPAA violations, but you will at some point see images of Ryan doing it old school, and he actually took a patient medical history on a 4-time folded paper towel on his knee, and he was very into it, and then
that's because he didn't have any tape to put on his leg to break from the tape. Yeah,
we looked for that too.
That's right.
That's good. We'll do it another day.
There was only so much going through the drawers around the house that I wanted to do without permission. But
yes.
But then he handed the napkin over to Beverly Hills Fire.
I'm not sure about the 21st. I got to check that date. But yeah, you know, the 14th would probably work.
Who am I muting? Was that Tony? I think was that you, Tony?
I think it's Tony.
I think I'm muting Tony. So there's actually a photo of the I don't know, someone from Beverly Hills Fire holding the napkin in one hand and the iPad in the other. Transcribing. Yeah, we do it. Oh man, it was classic. So I felt bad about pulling him away from the party, but we got some legacy out of it. So nice job, Brian. You deserve an award for the state.
Thank you.
Anyway, so
speaking of awards, Jonathan, you should enlighten the group on your recent recognition.
Oh, we can do that later. I appreciate it, but we can do that. All right, why don't we kick off here? Like I said, I'm seeing some faces that I'm thrilled to have on here. I don't know that all of you guys have had a chance to meet. So how about if it's all right with you guys, can we do a couple seconds or a couple minutes of intro of everybody and sort of say hi to everyone? How do we feel about that? We still got a couple folks coming in. So if that's all right with you, I'm just going to go down the list as I see it on my screen. So it might wobble. And if at the end of the day I miss somebody, do let me know. So first and foremost, because I'm seeing his face literally right in front of me, is Jeff Smink. Jeff, you there, buddy?
I'm here.
Tell the world who you are, buddy.
Jeff Smink. I was the EMS captain with Stockton Fire for about 9 years. I'm currently working with Life Assist as their capital equipment specialist, but known Jonathan since about year 2 of that little startup that you had.
What quite the arc, huh? It's been the adventure.
Right? Yeah. So
I look a tad older.
Trying to connect all those dots.
Still working on it.
And I'm saying if you had a piece of paper to write all that information down on, you're pretty much ahead of the game.
Oh man, it was just awesome. I'm just glad I got to photograph it in Beverly Hills, by the way. Just point out that, like, if there's any place that has the money to be able to afford, you know, it was anyway.
That's just how it is.
It was awesome. Welcome to progress.
Yes.
Well, good to see you, Jeff. Ms. Adams, you're up. Mrs. Adams, you're up next.
I like being up next. Hi, everybody. It's good to see some of you and some new faces. I'm Maggie Adams, and I own EMS Financial Services in just outside Philadelphia. So Tony and I know where all the good cheesesteaks are, and the best cheesesteaks are right in your own neighborhood. Do not go to the tourist spots. Never, ever go there.
No Patrigino's, huh?
No. No, just no. Anyway, what our tagline is practical ambulance reimbursement and compliance consulting. So as a company, we do a ton of audit work. That the audit business has been growing by leaps and bounds. Do a lot of education and speaking because I'm very shy. And I advocate for change in the industry to get people paid, what they're supposed to be paid. And my current battleground is I want us doing more work in our documentation, in the data we capture, so that we're getting data that the rest of healthcare is getting for the social determinants of health, because our crews actually see it. This is what community paramedicine is doing. This is what every emergency service is doing. This is what a lot of non-emergency transports are driven by. So I'd like to see us get better. I also have done a lot of work with NEMTAC, which is the non-emergency transport piece, and helping them. I've been on their compliance advisory board since they began, to help get better standards there. So I'm loving seeing this response to the real needs of people, the mental health, the physical health. And I think that if we have better data capture, we might actually get better response at the highest levels to get our industry financed and paid the way it should be, which is sorely is not, and that leads to all the other problems we're having. Our recruitment, our retention, being able to recognize the mental health of our own people. All this ties into the information that we have at our fingertips that we, I think, can get better at translating to the rest of the world. So that's me.
So obviously I'm applauding you loudly. Just as a thought, Maggie, let's come back to this in a little while, but I had a call yesterday with the folks from NEMSIS and the Office of EMS at NHTSA. And one of the things that they were asking is what they can do to help crews and agencies at the field level understand more about the data that they capture and how it will lead to all the things you just described. So at some point we should get you to either we could share this video, certainly, but maybe writing something up or whatever. They were asking literally 24 hours ago. They are trying to
last couple presentations I've done, and Ryan saw me do this at some other software company, and I spoke about this at state associations. This is my current one of my current topics. We don't capture it. It's there. It's in narrative form. But it's not in our data fields. And I think our data fields are very driven toward what NEMSIS wants. So NEMSIS needs to decide to expand its horizons a little bit to what's actually going on. But that might be a separate discussion that involves adult beverages.
Well, that's fine. All I'm saying is they're listening. Like they're asking for opinions. So to the degree that anyone ever wondered whether they were trying to do it, they really are. And so, but because they were reaching out to the software companies, given that you don't run a software company, they might not hear it from you. So if you wanted to pass that either directly, I'd give you their email address, or you can go through me and I'll pass it on.
And I know a few of the folks who are involved. I've been around a little while. Yeah. So I do know some of the folks, but this is In fact, I'm going to put something up on LinkedIn. If I don't get it to today, I'll get to it over the weekend, on what the rest of healthcare is doing and how CMS has approved use of more codes that are more descriptive. And we are not in our industry. It's in there, it's buried deep inside, but we're not getting it. And I think it would be very helpful to us. So that's my current passion.
Awesome. Love it. And love you. You know, you are a rock star. Anthony's iPad. Tony, is that you? Oh, go ahead, Ryan.
Real quick, I was just going to say, to Maggie's point, I did just recently see one of her presentations, and as usual, it was fantastic. It spoke to what I consider to be kind of the current mentality of the industry, and how Maggie and her organization are trying to change that and continue to help us progress.
Thank you.
Rock star status.
You can
All right.
come save me anytime with a paper towel to write my vitals.
You got it.
You heard it here first, folks. You heard it here first. All right, Tony, you just magically jumped up above Maggie on the list, so you go next. I don't know how to switch.
So I'm Tony Correa from New Jersey, and for better or for worse or ever, I'm kind of was wandering around the internet as we started COVID, trying to get people to look to the future to change the world. And in the second meeting, Jonathan jumped up and got involved. And by the third meeting, everybody here who I never knew, I got to meet because of Jonathan's connections. So somehow between Jonathan and I, we got this ball started. What my role in this is to continue to find ways to be innovative. I don't know, I think the term disruptor has been overused, but to continually look to how we can better provide services, get to really being a full mobile medicine. And Ron in Texas, and talk to Ryan while he was out at Indianapolis for a few hours. What he's doing is the direction we need to go, and having people like Maggie and Jonathan figure out how we're going to use the data to support where we're going. That one of the key points that we need to do better is with the political people. We need to get what's his name, Ron Morrissey, back together, the former mayor of Rockford, to help us get into the right political forums to make those moves. But my real role as part of all this is continue to push and drive to look at things differently, be open to different ways, and know that opportunities to improve and redefine what EMS and mobile medicine is always going to be there. My probably real passion in this, while I love the clinical end, my real passion is about compassion, people, interpersonal dynamics, and that type of stuff. Maybe Jonathan could help me talk to Jeff Frankel and somebody else to get them to actually hire Patch Adams to be a keynote next year at GEMS or one of the other conferences, to hear from a true leader in healthcare who's been doing it for over 40 years. So that's enough for now.
I was going to say, if you hadn't referenced Patch Adams, I was going to mention, I actually, every time you mention that, I kind of get a chill. What a remarkable story. And just, anyway, it's a beautiful thing.
And you know what? You write to him, he writes back. A couple of points to the retired captain from Stockton. You have a great Grateful Dead t-shirt at the Hook and Ladder, whichever ladder company that is. And Maggie, you're right. The cheesesteaks, even though we went and got stuck because we had family from Australia, gyms for an hour, going to the local places like Gitano's for me is the way you find cheesesteaks. So if you guys come to Philly or Jersey, we'll take you to the real places. And allegedly the best place for cheesesteaks in all of the United States is a place called Donkey's in Camden.
We're in Mount Holly now.
Love
I'm
it.
done.
Love it. Well, we owe it all to you, buddy. You started this ball rolling. Speaking of Ryan, Mr. Thorne, you're up.
All right. Well, good morning, good afternoon, depending on where you're at today. I'm kind of stuck in the middle. Just want to say it's been just such a pleasure getting to meet you guys over the course of the past, I guess, 2 years now, and just all the interactions that we've had, all the communication. And one of the things that brings me just tremendous joy is when I see, whether it's on LinkedIn, Facebook, or one of the industry trade journals, Just the work that this group is doing, whether collectively, independently, the way that we are all advancing mobile medicine and really pushing these ideals and just kind of the vision that we have for this industry. And I truly believe we're making progress, and that's substantial, especially in the time and the challenges that we're facing as an industry right now. For those of you who do not know me, I am the founder and CEO of South Carolina-based Thorn Ambulance Service. We do about 28,000 transports a year right now, but we are in the midst of, I think right now I'm working on 7 potential different hospital contracts. So I have a feeling the next year or two are going to be very busy for us. But I've definitely been able to do a lot of traveling, going to some of the national shows and getting to meet and have some FaceTime with some of the great people in this group. I don't know if Mark Devers is on the call or not today, but he and I have also stayed in touch, talking about some of the challenges, the rural challenges up in, upstate New York, for example. And it's just, to me, being a business owner and somebody who is so involved in the day-to-day operations of an ambulance service, it's so great to have this network of people comprised of really all facets of this industry, whether it's the data and technology side, finance, operations, you name it. I feel like this group has really given me an opportunity to expand and broaden my network, and also to have some people to lean on and vent to. I mean, it's not been an easy past couple of years for any of us, and I think it's been so crucial to have each of you kind of in my corner, if you will, and to be able to bounce ideas off of and learn from you. So I appreciate everybody on this call, appreciate all of your influence in my personal and professional life, and just thankful to be a part of the conversation. So
Ryan, stick a pin in the topic. I want you, when we're done, let's come back to what you and Tony talked a little bit about at FDIC, right? I think it'd be really great to hear what you guys talk about. Let's stick a pin in that one. And speaking of folks that get leaned on, someone that I lean on tremendously for a variety of commiserations. Terry, you're up. Or are we going with Terrence today? You're on the beach, Terry.
Which? Terry McGregor, thanks, Jonathan. I am with LA County Fire Department and spent the last 2 years buried in the COVID bunker, with many late nights with Jonathan trying to figure out how to manage our workforce and illness with COVID. But I'm back to my regular job in training in EMS and trying to blow up the Southern California EMS system from within and bring it into the 21st century. So hopefully we can make some moves. But totally to Maggie's point and to Tony's point, I think that the biggest hurdle, the biggest elephant in the room is identifying what we truly do for the healthcare industry, compensating us appropriately, and presenting the data to our elected officials, to our regulators, that will allow us to provide the care and to be compensated for the care that we're capable of doing, and to truly make us an integrated part of the healthcare system. The biggest challenge now is incentivizing us to do more when there's no way to fund that. Outside, the payers aren't paying, the hospitals aren't paying, the government's not paying, nobody wants to pay for this. So, if we want to make healthcare better in the United States, it's going to take a team effort, and outside of this group too. I think that we need to recognize that we don't really have a healthcare system. We have thousands of them, and so finding a way to bring all of these players to the table, as fractured as EMS representation is at the national level. We keep on creating more groups and more brain trust, more think tanks, but we've got to get the other ones on board too. So that's all for now. I'll soapbox more later.
Amazing. And he's a little bit further down the list, and I'm not going to jump, but I am going to say Ed Marasco's on here, and I know he's going to have some insight on the pick. Oh, he just came off of mute. Ed, you just actually jumped up my list. Why don't you go next? That's a perfect segue. I don't know. Zoom moves names around. Does it do that for you guys too?
Hopefully I get to the bottom of the list faster. It's the idea.
I don't get what it's doing, but that's a perfect segue to you, man. Speak some truth.
Thanks. Hey, thanks. It's good to be here. So I'm a 40-year healthcare and EMS guy. Started out as a paramedic in the field and spent time and air and ground, as well as a part of 2 large integrated delivery and financing healthcare systems over the course of my career. And one of the things that I think you guys have talked about, and it's something we need to continue to press forward on, is trying to find ways to demonstrate the financial value of what it is we do in mobile medicine. And so I think that's one of the passions I have and have been working on over the last 30 or 40 years in the industry. So, and I'm delighted to participate in the conversation.
Awesome. Well, I said we will want to tap your brain, and I think between Terrence's perspective and then you and Maggie together, there's not a whole lot here we can't figure out. Again, Zeke, I'll add to that as well, but he's further down the list too, so we'll get to him. Thank you, Ed. Glad to see you here. All right, who is 607-592?
Hi, this is April from upstate New York.
Hi, April.
Can you hear me?
Welcome. Yeah, we can.
Okay.
Welcome. Glad you're here.
Yeah, so I'm definitely new to the group, and I'm one of these oddballs that you guys are talking about. So I'm not an EMS. I am actually the CEO for a federally qualified health center, and we do a lot of value-based payment models here with our insurance companies in upstate New York. And so about a year ago, and I don't know if they're on the line or not, but about a year ago, we were doing some work related to COVID with the local fire and EMS services in the city, and they brought up mobile integrated healthcare and community paramedicine. And so I started researching that, and one of the areas that we struggle with in our practice is these preventable readmissions and these preventable ED visits. And so our hospital system here is not as collaborative as we'd like. And so I'm looking for a different way to divert people away from the emergency room when they don't have to go there. And my idea is to kind of do this mobile integrated healthcare and partner with EMS, and then do some shared savings with the EMS staff, so that the monies that we get and the savings that we get from the insurance companies, which can be in the hundreds of thousands of dollars a year, we can share some of that with EMS to kind of entice these relationships to grow, and hopefully show insurance companies that they are missing a large EMS in, and to save dollars in that way.
Well, April, besides the fact that you're going to have a lot of fans on this call, let me just provide some context that April and I connected. And again, speaking of kind of the way that these connections happen, Ryan, you mentioned we're making progress. I think April is an example of that. And also with a shout out to Martha from the National Association of MIH Providers. That's where April and I first met, right, April? Was at that event. And
right, yes.
Just to the degree that, the cross communication and the synergies, and look at what we can do when you've got these different organizations. I know, Tony, kind of looking at you on this one, because I know there have been moments when you've wanted progress to happen faster, but it is happening. Like the idea that we've got different groups in different places who are bringing people together who otherwise might not have met. And it's just a repeat of that process, and the serendipities will come. So April, you are very, very welcome. And I think even more than you, I think your perspective and the community that you are representing, this is going to be a wonderful conversation to be able to build some bridges. So thank you for being here. I know how busy you are.
Yes, thank you.
Absolutely. All right. Looking next on the list, speaking of upstate New York, I think this is a perfect segue. Mr. Bell, you are next on my list, sir.
Hi there. My name is Alan Bellum. I run Clifton Park Half Moon Ambulance, which is kind of in the area of Albany, which anything north of like Westchester in New York is considered upstate. So I am not upstate like Mark Devers, and so I'm somewhere in the middle between him and April. So that's kind of the geographic area of where I'm at. I've had a passion for, really delivering paramedicine in a way that it is beneficial to to people, and we kind of struggle with that because we know that taking them to the hospital is not always the most beneficial to them. And I don't remember how I got involved with the CoMMP group originally, but it's been very nice to have this collaboration, and it's gotten me into the connection with Jonathan, and we continue to collaborate and look for some stuff. But you know, the only progress forward is with data, and that is really where I'm lying and pushing and looking for that. I love to hear the things like social determinants of health, because they are huge in determining what is best and where the right thing is. I love hearing the terms collaboration and outside the box thinking, because the doing the same thing over and over again is just not working. It's not benefiting anyone. It's burning people out. It's frustrating people. And so I'm really looking forward to, you know, kind of this catch up with the group. I know we've all been kind of pushing our own things and our own agendas, but you know, it's always nice to get back together and hear where people are getting bogged down and or the success stories that go along with that. So thanks for the opportunity. And
Alan, can you speak a little bit to the group, as I think you do so with a remarkable amount of emotion and eloquence, about your passion for mental and behavioral health? I haven't heard as many people speak. I haven't heard many people speak as to the point on that need as you.
So I've been in EMS for over 30 years, and while still doing EMS, I spent 20 years in the police department. And I spent a lot of time when I was in the police department in the investigative unit and in the school resource officer unit. And I spent a lot of time dealing with people with mental illness, and how does that, you know, what is the best thing for them, and the stigma and everything that's associated with that. And upon my retirement, I had a great opportunity to go around the state and teach crisis intervention. And I really spend a lot of time with that, about the officer well-being and the, you know, which I brought over to the EMS side, and the provider well-being, with dealing with these tough incidents that we're bringing people to places they don't belong, and it's not successful, and it's not a great place for them. And, you know, it's not just mental health, but, you know, we deal with it. We have a number of, you know, dementia and Alzheimer's homes here, where we're bringing people out of their, I won't even call it their comfort zone. It's their home. And anytime they get out of that, it just disrupts everything, and everything goes into return. But looking at these determinants and ulterior things, you know, that we can do, and I'm on a big push with, you know, behavioral health telemedicine now up here, that we can try and run these through, because, you know, we're just bouncing people all over the place for no reason and getting no solutions from it. And these are, you know, either family members or, so, you know, people that we deal with all the time. And you know, we're here to help people, and without that stuff, we're not helping anybody. So.
Well, I will say, you know, just as a point, bringing you folks, I was thinking is that I hope we're going to let's take as long as we need for everybody on this call to know each other today. You know, Alan, I actually, in all the conversations you and I have had, I haven't had you talk to me too much about your experience as a police officer. And I think this kind of conversation and the cross communication of knowledge, who knows what, whose background is what, is exactly what this is all about, right? You guys are my passion. It just gives me a chill when I hear you guys talk about not only your experiences and the perspectives you bring, but to know that each of you needs to learn from each other. And I learn from all of you every day. And just imagine the things we could do if everybody knew everybody's history, right? Nobody's in this industry because it's easy. So to the degree that everybody's got something to offer, just what a wonderful set of perspectives that I can tell you specifically, Alan, I'm going to want to pick your brain on some of this, because I'm starting to engage with law enforcement more regularly, and I'm learning how to talk blue. It's actually been interesting. Like, I speak red and I speak white, right, for the last more than a decade, and I need to learn how to speak blue, and the sensitivities are quite different. I'm learning that. So, you know, I think to be able to experience one another's expertise, I mean, what better can we do? So, all right, what about,
can I interrupt
ahead.
for just 1 second?
Of course, please. Not a lecture.
Well, I was going to anyway. I thought it was polite to ask. We all have a list of who's on the call. Let's make sure we connect with each other. LinkedIn is probably the best way to do it, because though we have this opportunity of a call, where we are visible daily or weekly is on the social media platforms. So we can see what each other's doing and see where maybe somebody's working on a project that we'd like to either follow or know more about, or have our own needs. And that might be just a reminder to do that.
Yeah,
we have the comp group. We have the comp group on LinkedIn. So besides connecting each individual, please go and join the comp group. And you know, that way if you share, all of us are going to get a message.
that also on Facebook, you know, and I think Tony, you talked about the history of how we made this group a thing. It's worth remembering, and I think because we're all busy, life has gotten a lot busier, right? I think we can all agree, than 2 years ago when things ground to a halt for a while. But in the first conversation that you convened, Tony, I think we had, say, about 16 people, something like that. And in the second call, we had about 30. And then at one point, I believe we had about 70. And then following that in the online forums, really shuffling in and out, people were joining and leaving the conversation as their schedule allowed. But we have about 700 people following those different groups right now who get those alerts, who watch these videos. I mean, I see the video counts, you know, in cases like there are people who watch them. It comes up in conversation more than I expect, for sure. And again, I mean, literally at the level of the feds. I mean, people say, you know, hey, these conversations, even though they can't make it to the meeting, they do follow up on them. So yeah, I think that's a great point. And if you're not on LinkedIn, I will say I blinded the email list because I don't know who wants their emails, especially personal ones, shared. But if anybody is not comfortable with their email being shared, or specifically is okay with it, feel free to put in the chat if you're okay with it. And likewise, if there's anyone you don't. In fact, thanks, Isaac. Certainly putting your contact info right here in the chat's a wonderful thing, and we can share that as well. So, but guys, if
and I also have that other email list. So I created that other one that I'll share with everybody. I know about 3/4 of the people on now are in that email list. So we could add to that and then find a repository to put it where everybody can access it, because those people that are going to be on the list are going to be the ones that are going to say, yeah, you can contact me.
Outstanding. All right. Well, thank you. Alan, you're awesome. Maggie, you're amazing. And I'm going to move due east to someone else who likes to blow up systems from within. Chief Grew, you're up. Talk about a revolutionary mind. Art Grew often is one who comes immediately to my mind. So you're up.
I don't know about revolutionary, but you know, maybe wanting to make people bring out their pitchforks.
Hey, you know what? What is it? First they hate you, then they call you crazy, something like that, and then they all realize you were right all along. You have done things that you have done. So
and then they want to work for you.
Yeah. So geez, I've known Jonathan. It's been quite a while, but so many things that you know we're looking to accomplish. But I think the biggest thing that, you know, we're really finding is, so we all have data, right? We all use our data, and individually, at least for, I'm sure most of us on the call, we have great data. Collectively, we have crappy data. And I know this is where some of the pitchforks come out, because we all use different renditions of what we call our data. So individually, we're able to use that data to do great things, but collectively we can't. And we see data errors constantly, mainly because we touch the same thing over and over and over again, and drives me nuts. Right? We've seen services over and over again that complain that the biggest thing is that employees hate doing reports. So when we look at our data, it's driven by the lowest common denominator within our service. That's where that is where our data levels resides. And one of our biggest pushes is to try to fix that problem, at least within our own internal system, because it really, patient names, we can't even get them right, and that is not just a problem with our system. That's a problem, nationwide. When you look at reports, you can't bill to Medicare if the name doesn't match what's on the Medicare card. So we talk about reimbursement. That reimbursement goes all the way back to the simple things that collectively we struggle with. So I guess that's kind of my current, big push is how do we fix that? And how do we fix that so that we can make it easier for our staff? So yeah, that's my latest pitchfork endeavor.
Sounds like you need some pre-hospital pipes.
Yes, well, we have some, and we're looking at some others, but it's going back to that collection, right? So we all touch the same thing over and over and over again. We don't share it. And yes, I've had many conversations with Jonathan over this.
Well, and so let's take that segue. By the way, like the next three people on this list are extraordinarily in the weeds on data, so you're in good company there, Art. But here's a fellow who is working with his ecosystem in a remarkable way. Dave Moffitt, you're up. In terms of talk about what you're doing, the many things you're doing, but when it comes to getting an ecosystem and actually care about the data and ask you guys for it, you've got some remarkable examples.
So, hi guys, everybody. Dave Moffitt, captain with Phoenix Fire Department. Hey, Anthony. I work in our Emergency Medical Services Division and also in our Homeland Defense Bureau. And I'm neck deep in the planning cycle for Super Bowl 57 coming up in February of 23. I work at our ACTIC, which is our fusion center, and I've got a lot of spokes coming off the hub for the things I'm looking at. Can really identify with what Alan presented on in terms of we're running, I think so far we're about 20% up over last year's calls, and last year we were over 10% over the prior year's calls. That means we run about, well, I think last year we ran 220,000 EMS calls, so we run a bunch. It sure seems like, just in my experience here lately, that we're seeing more and more homeless people calling us, and it sure is a square peg round hole that people are utilizing 911, the fire truck, and the emergency room when they really, that enables them because they're getting enough of a taste of the healthcare system, but it's not pushing them down the right path to care because they're not heading down the path to primary care and behavioral health and drug addiction treatment and all those other things. And so it's a difficult and nuanced thing. And a lot of this that I present to my bosses, and it's not as though they don't know, they certainly do. But in this conversation, when we reach out to our community and to stakeholders, one of the narratives that I find myself defeating, and I'm just going to use two subsets of what's out there to talk about, which is maybe our homeless population and our veterans population, because we really struggle with our veterans hospital here, is that people will say the veterans hospital folks, if we're not careful about controlling the narrative, they're going to say, well, you don't care about veterans. Like, what, you don't want to run these calls, you must not. And that's really the truth is, no, I care about homeless people and veterans enough that they're not seeing the right levels of healthcare and not having consistent visible interventions in their life, that they're stuck in the cycle of using the fire truck, the ambulance, and the emergency room as a very poor replacement for the definitive care that they should be getting. And I think right now as a community, what I'm struggling with is where is that message best delivered? I wished it was at the 60,000 foot altitude. And I don't know if that means a mayor or a governor. I'm not exactly sure, but someone else out there to leverage the rest of the healthcare and behavioral health community to own these people. I think that what I'm seeing, and again, it's really hard for me to be in the position, say, of just the behavioral health world in there. And I don't want to craft this message that they're not doing enough. What I think is going on is they'll say, well, look at all the people they're helping. And I want to spin them around and have them look and say, look at all the people that still need help. That's where my concern is with that. I think separately in the stuff that I do within the Homeland Defense realm and our fusion center and the Super Bowl planning and a lot of other things coming up, as I'm trying to look at big picture emergency management stuff as it pertains to EMS. Keeping little problems little, the interagency cooperation, which I wouldn't say necessarily that we do it the best, but if there's someone that does it better, I'd like to meet them. I think we do a really good job of coordinating with all our partners. If it's Homeland Security, FBI, State Highway Patrol, all the local law enforcement and EMS and fire agencies that are around us in there. But it's a giant elephant to be eating right now. It's massive. One of the resource working groups that I'm working within is the public health and healthcare group. And so we're getting our heads around a Tier 1 event with the potential. There's 9 cities in our area that are establishing incident management teams, including Phoenix. There are probably 15 different concert venues. Scottsdale is going to have the Waste Management Open and the Barrett-Jackson car auction. We're going to have the NFL honors event. There's a big media presence that's here. Obviously the NFL footprint where the Super Bowl is taking place, but also all the other ancillary NFL and other, when all these other cities are taking advantage of the couple 100,000 people that'll be visiting for that. And then the Waste Management Open, sometimes they can have as many as 150,000 visitors a day in that event too. So lots of planning going on, lots of coordination efforts. I think we're doing a good job, but I also know that there is still a lot more to be done out there. And I'm looking forward to good ideas and great technologies to leverage as force multipliers to make our jobs easier in that environment and be good at sharing resources and information.
Amazing. I find myself humbled by all of you guys being on here. The stuff you guys are doing is like my world sometimes feels very small. But when I realize all the many things you guys have going on simultaneously, no one's got enough hours in the day. Thank you for all that, Dave. And I'm sure there are people here who are as fascinated as I am of questions and whatnot. Before I move on from you, do you want to tell the story of the head that's behind you, or should we leave that for another time? Oh, that one.
Oh, well, obviously I like to hunt. I've been to Africa a couple times, and if I'd spin my camera around, I'd showed you the room of death, but Jonathan's experienced it firsthand. He slept and had nightmares in this room once. So.
I'm pretty sure that one talks to me. That one. But anyway. All right, thanks. Well, we'll keep in the same geographic area. I was going to point out that we had gone from New England to Arizona, and just, right now I'm pretty sure the weather itself couldn't be more different. It's going to only get more different as the summer rolls on. But now there's this coverage area, this sort of technology merging between Arizona and Colorado. So we're going to move from up one state. And Zeke, you are next, my friend. Talk about what you're up to. Tell the world who you are, and what all the different things that make your perspective pretty much different from everyone on this call.
Well, actually, I was just going to duck out.
Mention.
I was until Wednesday the Emergency Services Director and Special Projects Counsel for Contexture, which was the merger year and a half now of the health information exchanges in Colorado and Arizona, so Carrillo and Health Current respectively. But I am not there as of this Friday, and I am going to go it's my wife's birthday, so I'm going to go take that. I'll take priority over this. So I just really want to stick my head in and say that, reiterate what I've said a number of times in my intermittent attendance with the group, that I think that there are a set of conversations that sort of match up with my weird mashup of interests, and that have to do with both the data components and the policy around them, and but ultimately are about thinking about how to scale operations in such a way that they provide the broadest service and sort of throughout the disaster cycle for lack of a better set of terms. So I just want to say I'm still in and interested in hanging out with you, and it's definitely been a group of people and a set of conversations that I don't see happening anywhere else. And so I thought I'd better show up today, even though I've got a couple other things I got to go do. So
Well, I will say we're happy to have you. As far as I'm concerned, I'll take what I can get. So welcome. I will say I just got a note from Victoria, who said she's here but can't get into the room. So I'm going to try to figure out what that's all about. In the meantime, though, let's continue the in the weeds of solutions, solving big picture challenges with Fred. Fred, you there? Because this guy's got a perspective on what information can do to change the world, and he's got the chops to pull it off.
I am here, but I feel somewhat inadequate after all the people have been speaking before me. I'm honored to be here after all the stories I just heard. So I'm Fred Wilkins. I'm the president of VLI Tech, or EMS Technology Solutions company located in Houston, Texas. And we have lots of wonderful customers and partners across the U.S. And I think Jonathan probably got me into this group way back in the day. And our goal for the last 2 years has been to find a mutual customer. I think we've nailed that down, Jonathan. I'll talk to you about that later next week. But so we started years ago. Out of the main reason for us our driving force was to make a software we used better, to fix the holes in it. And we ended up creating our own company to do that, to plug into that software. And we found out that all the other software in the industry had the same holes. So we started plugging into those softwares to provide actual current 21st century solutions to software that was sometimes feels like it was written last century. And that's what we've done. We've grown that from there into, we do cloud hosting for all of our EMS partners across the country. We do these specialized apps, and our main focus is just to be a data integrator.
Well, welcome. And like I said, I think you've undersold your perspective just a little bit, but thrilled to have you here. And like I said, if you guys don't already know Fred and his team's work and just their ability to make sense of, in fact, Art, to your point about how organizations, individually may have data, but cross-sectionally, it's not all that great. Fred is a master with that. So we'll have to, it's good to have you here, and hopefully we'll have you speak up on some of those things now or later, Fred, whenever you get a chance. Hey, I think I figured out what Zoom is doing and why it's jumping around. It's trying to bundle people accidentally by their geography. It seems to be what's happening. So I'm going to go south from Houston to Brownsville, Texas. Hector, you probably saw that one coming. You are next on my list. Pretty much due south from Houston?
About 5 hours south of Houston, more or less, depending on how fast you're driving.
Welcome to the group. You again are an individual I have enjoyed each of our conversations. So I think you have a remarkably unique perspective and ecosystem. Tell the group what you're doing, what's keeping you up at night.
Well, it's nice to meet everybody, and thank you for the invitation. Honestly, I feel like just a fly on the wall listening to all of these introductions. So privileged and honored. So thank you very much. So I'm Hector Martinez. I'm from the Brownsville Fire Department. Currently overseeing our mobile integrated healthcare community paramedicine program. We started towards the end of 2019, got derailed in our initial mission, and in 2021 took on the initiative of vaccinating homebound patients. I think we did over 700 homebound vaccines, or shots rather, over the course of 2020. And now that 2021 rather, now in 2022, we've reshifted our focus into handling readmission prevention and managing some of our high 911 utilizers. Just for a little perspective, Brownsville is the 18th largest city in Texas out of about 1,218 cities, 145 square miles worth of geography. We have about 180,000 documented citizens and an unknown number of undocumented citizens in the city that the census doesn't always get to. One of our really big focuses has been managing diabetic patients. They have a very, 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 very high prevalence in this area. We're at about 31% roughly prevalence of diabetes in adults in this area. I think nationwide the statistic is something like 9.3. So we have a very large population of diabetic patients, and that's been one of our focuses. We do about 23,000 to 25,000 EMS calls for service a year, and that's both 911 and non-emergency. So in comparison to Phoenix, I think it's probably just a drop in the bucket based on what I was hearing. So what we've been doing really is focusing on hospital readmission. A lot of these patients, because they're undocumented and uninsured, they use the 911's 911 in the ER setting, kind of like a primary care physician, because of lack of funding and in their own homes and lack of insurance. And that puts a really big strain on the system down here. Nationwide, I think everybody knows there's a shortage of nurses, there's a shortage of paramedics. So we kind of took a look at what was going on here and saw that, by preventing readmission, we could have an impact, a good impact on the hospital for obvious reasons, and also reduce the strain on some of our medics, by keeping the hospitals for just for the ERs rather, just for true emergencies. And then with our high utilizer group, currently we're working with 9 patients that made up about 200 calls by themselves last year. So we're working with them to try and find the resources, but we're in a really funny area because there's not a ton of resources, at least openly available to us, to get these people the help that they need, or get us the help that we need to be able to provide them the services that keep them healthy. So one of the things that we did that has seemed to improve our efficiency is our fire department actually partnered with our public health department, and we're actually taking this on together. So they're using all of their masters of public health students and their homework to make charts and make surveys and to put together really big research papers as part of their schooling. So they're actually inviting them in to help us put together all these statistics, and we're looking for a way to make our community healthier. And so with public health department, the city itself, we've actually started hosting community fairs. One of the things that we found is the highest prevalence of the diabetics in our area, of that 31%, all live within 6 miles of each other. And that area is about 4 miles removed in a straight line from the border. And so we've taken into studying socioeconomic status, we've studied the availability of food, highest level of education, and we're kind of looking at all these things to try and find the best way to help people. So we had a conversation, or not a conversation, but there was a post on LinkedIn the other day that kind of brought up the question, well, how do you show your value to someone that doesn't necessarily agree that MIH is going to be an effective program? And I think for us, it's by being specific to our need. John Oliver, I think, said one time, if you've seen one EMS service, then you've literally only seen one EMS service, because there's such a massive disparity in the things that everybody's doing. And I think the same can be said about MIH. It's really nice to see different programs and getting on groups like this to kind of find out what everybody's doing and how they're doing it and what they're using to be successful. And one of the big things that we're looking to do, and part of the reason that I connected with you, Jonathan, was we have all the data. We just don't know where to put it, what to do with it, what's valuable, what isn't valuable, and who needs to see what. So I'm actually really excited to be in this group. There's some people in here that have already piqued my interest, and I'm really excited to just learn from everybody. So thanks for having me.
Outstanding. I mean, again, you couldn't have stated the purpose better, Hector. So thrilled you're here. Glad to have met and started chatting with you. Just again, I will
Jonathan,
make sure that. Sure.
Just to go back on the public health, this is one of the reasons we got to get Larry Morrissey back engaged, because the mayor of Rockford, as you remember, he said, I became aware that my community was in the healthcare business, and we got to get mayors and county commissioners and state senators to understand that just like they're in the fire and police business, they're in the healthcare business, and it's much more impact on their community. No offense, I'm a firefighter, was a fire director, but it has much more impact than fire and police does. And I just wanted to throw it in because it fit. And I'll go back to
no, Tony.
The lake.
Tony, I think it's a perfect point, and not for nothing, but you know, Hector, you mentioned listening to Moffitt, kind of seeing how communities compare. And I think one of the things that we've always talked about in this collective, and that maybe with the fact that the feds and others are listening, instead of going back to what Maggie was talking about, we said at the top here, there is, not only are there open ears, and they really are, you know, again, sometimes it takes longer than we'd like, especially during a pandemic, but it's there. But I also think there's safety in numbers, right? And that's something that, I mean, we've talked about here on occasion. I've certainly had conversations with people offline about the idea that, you know, one of the purposes of having a group, right? We talked about this when we created a name for CoMMP, right? Was the idea that the group can make a statement that individually we might not be able to do and feel as comfortable talking to our local politicians or a you know, the member of the news media, or putting out an article. I remember a couple years ago where someone said, yeah, the safety of setting up an association is that you can say things that would otherwise get you in trouble, and you have the deniability of you weren't necessarily the one who said it. You know, so I think if we can learn from each other, Tony, and be able to have that conversation with those politicos who may hold the purse strings, you know, or get things moving, and whether there are 16 of us on this call or there's 600 of us as a group, right? There's not really anybody who's going to know which individuals put pen to paper other than the people who did it, right? So for us to be able to do that, I think, actually, since I see that Dave Mitchell just put his info in there. Thanks, Dave. I'm glad you're here. I'm almost at you, so not just yet, but I think the place that Dave and I actually met years ago was through the International Association of EMS Chiefs, which is also where I met Zeke. And the opportunity, you know, afforded by that kind of group to bring together big brains, but then be able to put together an output, which was a document or a statement or a position paper or whatever it is. And it was the collective, and they got together and hammered it out. So Tony, I still think that's something that's the kind of output we can do. And I don't think we necessarily need everybody working on it. We've seen that already, but we can generate publicity. We can generate white papers and things. And we have been, you know, everybody's busy, but we have been. There's quite a bit of content now that we will need to update on that website. The comp.org is still there. If you guys are not already familiar with it, spread the word. Comp.org with 2 M's is very much still there because it needs to be updated. But it's there, and we should put some content on it. Speaking of issues with diabetes to a variety of, and the challenges of dealing with public health, I'm going to go north from Texas to Isaac in New York City, because that's kind of a different world when it comes to politics and everything else. So Isaac, you're up.
Thanks, Jonathan. You know, I appreciate everything that you're doing as a fellow entrepreneur. I was knee deep in studying the economics of community paramedicine, mobile integrated health for senior care, where I'm the director of finance, you know, here in New York City. And then something caught my attention because in a lot of ways, the industry is on fire with staffing challenges and the world is on fire with inflation. So that kind of sidetracked me, honestly. You know, and actually that was what originally attracted me to CoMMP, was a big focus on, you know, these care models, which are really revolutionary. So, but I got distracted, and I said to myself, how do you fix these things? And the short answer is there is no solution, but you can help a little bit. And so I was thinking about it, and I said, well, insurance companies, especially if they're not contracted, you bill them, let's say $1,000, and they pay $500. What happens to that other $500 that you billed? It gets adjusted off. And the question is why? There's no contract. There's nothing that gives the insurance company the right to not pay your full charge. And so I said, I think there might be an opportunity. Well, it's not going to fix all the staffing challenges, the financial challenges that come out of that, and the inflationary problems that we're facing, but at least to help EMS agencies in some way financially is to go after those underpayments. So I started in January, and you know, we've really taken off. We have clients in 6 states already, and I'm doing my small part to try and help the industry. So I really appreciate this forum, and I'm really passionate about you know, financial sustainability of the industry and the provider community. And so I'm looking to you know, meet with providers to see how I can help them, but also to the folks who service the industry on this call, you know, to partner in ways, you know, strategic partnerships where, because, you know, I think we are really trying to help the provider community together. You know, we're looking to build out an advisory board, for example, and other sorts of strategic partnerships. So I'm really excited about the effort. You know, John and I have been going back and forth to solve some of New York City's challenges with, you know, interoperability and so, you know, I could go on for hours about that, but this is a really great forum. So thank you, Tony and Jonathan, and it's great to see all the familiar faces, and Maggie and Ryan. Well, I can't see your face, Ryan, but you know, I just want to say thank you for putting this fabulous forum together. And you know, anyone should feel free to reach out. My contact information is in the chat.
Well, we
and Isaac, I was just gonna say, Jonathan kept me up way too late last night, so I look terrible today. So that's why I'm not on camera.
Just wait, because tonight's going to be longer, my friend. It's actually Friday tonight.
I know.
Take a nap, baby.
Not Zoom worthy. There should be a category, not Zoom worthy.
Well,
yes, my face is not Zoom worthy today.
There are actually beauty consultants for Zoom. Just throwing that out there, and I am clearly in the wrong business, because if that's what your daily job is, I missed the off ramp somewhere. Just throwing that out there.
You may have been in California a little too long.
No,
that sounds very California.
I'll say we'll have to see where they're based. I almost have a feeling they're probably not, because they're remote too, but who knows. All right, we're coming to the bottom of this illustrious list. I got 2 more folks left. So Dave Mitchell, you are up, and then we'll pass over the Rockies after that.
Awesome. Hey, thanks, Jonathan. I'm a long-time listener, first-time caller. I've heard a lot about you guys from Zeke, and I'm very excited to be talking to a group of really smart, engaged people about something other than COVID. I have laryngitis right now, so I'm hard to hear, and I'm in Nebraska instead of Colorado, Jonathan, because my dad took a tumble and had to come home and help him out with some stuff. So I basically stuck around to meet everybody and say hi to you. And I'm the EMS chief of Arvada Fire in Arvada, Colorado, and the immediate past president of the International Association of EMS Chiefs. I'm excited to be part of this call, and I hope when the next one comes around that the invitation will stand, because I'll have the ability to hang around longer. But I basically wanted to say thanks for the invitation, and thanks for letting me listen to all the cool stuff you guys have going on.
Well, thanks for being here. I hope your dad does well. Hope you feel better.
Thanks, man.
Tell them this is like the mafia. Once you're in, you can't get out. There's no out. Tell them, Maggie. The Philadelphia contingent will take care of that.
Perfect.
And you notice how it's the thing that makes it so Philadelphia, of course, Tony, is that you're threatening, but with a smile.
Yeah.
Sweet threats of violence.
And with a great environment, great background. I
Right.
do it, with love. It's all with love.
It's all with love.
And we'll feed you. We'll feed you first.
And then to the fish. Right?
And then you can become, the fish are hungry. You have to be well fed. So they are.
It's a circle.
Circle of life, yes.
There it is. All right. Well, as Colorado has of late become the center of the mobile medical ecosystem, or at least one of them in this country, I find what they are doing in all parts of that square state to be unbelievably remarkable. And in pockets where we need to shed more light on them, I'm going to look to the man with the momentous beard for the day, last but very much not least. Although I don't actually know where you are today, so you'll have to tell us, Ruben, where you are at this moment. But Ruben Slim Farnsworth, take it away and bring us up to our. I know you got about just under 20 minutes left, so you'll intro us to our next topic.
Okay. Yeah, Ruben Farnsworth. I'm actually at home in my office today in Delta, which is rare, but yeah, I'm in my office trying to get some work done, being distracted by this. I run our MIH program and our ET3 program, our ET3 model. And our big focus is on advanced clinical care in the home. So we use RNs and paramedics, well, community paramedics, and we do all kinds of things from vaccines with the health department. We're partnered with the health department, area agency on aging, local hospitals. We have contracts with payers. I heard some comments about, that it's nearly impossible to get paid, and there's some ways to do it. So we have a program that does not rely at all on grant funding. It's actually a revenue center for our agency rather than a cost center, and do a lot of cool things. We do some stuff with Children's Hospital, infusions in the home. We do a lot of telehealth, concierge medicine, and lots of exciting things happening.
Well, and as I kind of suspected, Ruben undersold himself because he relies on me to brag on his behalf. But I will say, well, I'll just tell a small anecdote about a time that I had a technical conversation with Ruben, and we were talking about how to do something when it comes to, as it turned out, I think it was an experimental infusion or something like that. And I remember saying, next time, well, I said, why are you doing this? And well, I'll let you tell the story, but the bottom line was it has become, and was at the time, one of the most emotional case studies that I had heard of where mobile medicine can make an impact. And I believe the words that came out of my mouth were, Ruben, next time lead with that. So why don't we take a few minutes? We'll talk about some local innovations here. Again, kind of want to bring it back to the crosstalk between Tony and Ryan. So you guys will be up next. And I will eavesdrop collectively on the two of you. But Ruben, why don't you tell the group about the boy, especially since we have the permission to be able to talk specifically, right? And just tell a bit about, because I honestly, everybody, okay, if you're not crying by the time you're done with this, it's truly remarkable.
So we were contacted by a specialty pharmacy out of state that said, hey, we have a child that needs an infusion and we can't find anybody to do infusions at home. Can you do that? And we said, yeah, as long as it's ordered by a physician, we can absolutely do that. So we ended up partnering with Children's Hospital out of Denver and a specialty pharmacy in the Midwest and a drug manufacturer on the East Coast. This male patient has Duchenne's muscular dystrophy, and the family was participating in a pilot trial, experimental trial of this exon skipping medication that skips the 45th exon on the gene that codes for dystrophin, because people with Duchenne's don't make dystrophin. And essentially this medication goes in at the molecular level and it skips the 45th exon, kind of like a jumper wire, and allows the patient to code for a shortened version of dystrophin. So it won't cure Duchenne's, but it will lengthen the young man's life and lengthen his quality of lifetime, allowing his muscles to work better. So basically the family was having to drive to Salt Lake, which is about a 10-hour round trip in driving, and they were doing that twice a week. Our team was able to start giving those infusions through his port in his living room. And, you know, kind of the wonderful thing about it was for a child with a terminal illness, there's really no greater gift you can give the family than more time and more quality time with that child. So, yeah, it was pretty cool. We did that for a while. And then one of the people on my team actually taught the mother to do the infusions, and we took it in a stepwise fashion. And now she does the infusions herself. And if she runs into any challenges, she has us on speed dial, and she just calls one of my lead nurse, and James will talk her through it or go up and help her if she needs it. And yeah, so really made a positive difference in that family's life and that young man. And so it was a cool case. Really, really good use of what we can do.
Ryan, why don't you tell what you just texted me, man?
Yeah, no, absolutely. That gives me chills hearing it from you there. I know, Jonathan, you kind of shared a brief version of that with me in the past. That's honestly what I think catapulted your initiative, the Rush Initiative. For those of you who are not familiar, rare and underserved healthcare needs specifically for the pediatric population, and trying to take that to communities across the country where we can do similar type work, where we can give those families and the patients the quality of life that they've been seeking, eliminating a lot of the travel and expenses related to receiving medical care, and finding an opportunity to deliver that care within the homes to keep patients and kids, you know, in areas that they're most comfortable instead of within the walls of traditional brick and mortar hospital. So, but Jonathan, since it really is your initiative and something that you crafted and created, I mean, I'd love for you to kind of expand for the team here on kind of what we're doing and the progress we're making.
I appreciate it. So it's extremely proud, and one of the reasons why Ryan and I were together last night, which you'll see some photos from it later. Some are more serious than others, but it was essentially our introduction to the world, sort of our soft launch, if you will, of this Rush Initiative for Children. Slim, you obviously had a direct impact on this, as you know. What essentially Ryan and I are doing, and again, I'm gonna connect some dots for you guys in a second. That I hope, really, as I'm looking at Tony, I'm thinking of you, man, because you've been pushing on this idea that, like, we need to show progress. And while again, it's not always as fast as we'd like, progress is coming like a freight train. And it's the most wonderful, welcome freight train that I think our crazy profession here could utilize. So Ryan and I were actually together at a conference. It was the Atrium, right? I think it was Atrium. Yeah. So
yes, Atrium.
Yeah, Yep. Atrium Health Conference in Cherokee, North Carolina, where, fun fact, I was given 5 minutes to talk about the economics of community paramedicine, and 45 minutes later, no one got their break. Sorry. And I did it all off the top of my head. So I really have to give kudos to those folks.
I would just like to say, surprise, surprise, surprise.
I know. I just can't believe they let me go. Oh, God. So anyway, yeah. So basically, there was a fellow in the room named Daniel Linkins from Virginia. And he, like us, like all of us here, is really trying to make a dent in his community's needs. I want to make sure, as this is going to be recorded and we'll share it, we'll give him a shout out. Daniel is one of those folks who knew what was needed to be done, understood his community's needs, has wonderful relationships with a lot of the providers of various sorts in his community, and was kind of looking for something to cut through the noise. And again, Tony and Maggie, you guys have talked about the political involvement, like the need to engage politics and the need to understand those community needs. And so we got to talking at that conference where Ryan and I were both there. And Daniel was like, I know we need to do this CP program. Our community has needs, they fit the model, but we're trying to figure out how to, again, cut through that noise and kind of get started, right? Just start with some momentum. And I don't remember who it was, I apologize, but someone today was talking about how their community has issues related to dementia and, you know, elderly folks, and we talked about diabetes. And so it was really kind of which of these is the low-hanging fruit. And so after talking, I think Ruben and I had this conversation a couple weeks after that conference, and I called Ryan and I called Dan, and Dan likes to point out that apparently I called him at like 10:30 Eastern time, yeah, PM. And I said, I have an idea. And the question was, have you ever encountered a community paramedicine program focused specifically on children? And the answer was no. Some of you guys know what I'm doing in Oregon as far as providing a registry of pediatric medical complexities, these kids that have really serious illnesses and disabilities, and making sure that responders are aware of that. It's called the Hero Kids Registry, and the Oregon's going to change the world with what they created there. But I basically sort of these items rattled around in my head of like having a CP model, wanting to do this, knowing the needs, knowing what our team here is capable of, and the kinds of conversations where we've said, and this is where Ryan and I went with this, is the community has a need. The local county fire department, which is Rockingham County Fire, actually approved the idea or this model of a pediatric community paramedicine program that was tech enabled and interoperable in a single phone call. I mean, talk about the ability to do it. And then the question became, okay, so if you've got this idea and you know you want to, but you don't have enough people living there, right, to be the providers, they don't have extra hands, right? And you know, the county is not going to be able to increase its roster just because they have a good idea. So when Ryan and I talked about this, it really was this question of what can we each bring to the table, right? And what Ryan and his team and others on this call are so good at is basically bringing those capabilities to bear, figuring out sort of what tool on the multi-tool needs to be utilized, and the ability to find people, incentivize people, train them, support the local operation. So instead of being a replacement for the local fire department or the local EMS agency, it's really about saying, what are your needs? And if someone like a Thorn ambulance service can basically support that and put somebody else's patch on their arm, right, then now you can solve the personnel crisis by moving pieces around on the chessboard, and the community wins. And the local agency wins because they're the brilliant ones who said, let's work with somebody innovative, and not necessarily have to do it all ourselves. And so again, Tony, you're front and center on my screen here anyway, but you know, really, this is the kind of stuff that was your dream, right? Again, 2 years ago, you know, you're the speaking of the mafioso, you're the godfather of this whole idea. And so it is really quite tremendous to think that a conversation with someone like Ruben plugged into the context of someone like Daniel at a conference where Ryan was there, and for us to be able to say, and now here's a community that's trying to figure this out, and the economics can be solved because instead of a hammer looking for a nail, there was a nail begging for a hammer. And all we needed to do, and again, we remember how we talked about the archipelagos of success, right? And the bridging of the islands of success and popping holes in the silos. And we've used these analogies so many times. And when we do that in this collective, we can solve problems that were previously intractable because the ideas didn't have to come from any one of us, right? It came from each of us as the facets of the prism, shining light on each other. And it's just been a tremendously, I mean, it's literally the most emotional work I've ever done. So I'm grateful to Ryan for having come out here. You guys will see the photos. Now you'll know that the Rush Initiative for Children has roots in CoMMP. And as we go forth, and we've already got other states and regions that are asking for this, because again, it's all about the children, right? I mean, there's no one who politically would dare say the kids don't deserve help. And it turns out, as Ruben pointed out, there are some real dents that we can make in these needs. If we focus on a population that everyone wants to serve, but there's not enough pediatricians to go around, right? And especially in in rural environments, in underserved communities, in care deserts, and that sort of thing. And so we have the ability to say, by slamming the brains together, we've come up with solutions that none of us had individually solved. And so as we get to the top of the hour, I will ask just a few minutes here for Tony and Ryan to sort of talk about what happened when you guys got together. I think there was someone else we said to put a pin in, but I really want to hear about that. And I also want to just say that we just spent 90 minutes introducing each other. And in my personal and professional opinion, that was the best use of 90 minutes that I think we're going to have all day today, aside from when I'm going with Ryan to dinner tonight with his new wife. Congratulations. And that'll be another fun 90 plus minutes. And tomorrow I will roll him out of the bar. But nevertheless, I hope all of you, we will share contact information. We will have more calls like this. We will try to respect everyone's schedules. But what an amazing thing for you guys to meet each other. Some of you, it's meeting everybody again and talking about what we're doing. For some, like April and Hector, Jeff, welcome or welcome back. And I really hope that you guys get in touch and we cross communicate. Victoria sent her love. She said she couldn't make it after all. But she's another person who has taken this ball and run with it. She is an amazing champion for all things integrated care, not just mobile, right? I mean, the mobile is almost an adjunct. It's really just the idea that care where it's needed. Going back to Alan, to your point, oh, you were the one who talked about dementia, right? So, the ability to say, bring the right care where it's needed, and it may not be our own service, it may be a partner. So wonderful, wonderful work from each of you, and anyone that needs to communicate and doesn't have contact, I'm happy to do it. So Tony and Ryan, why don't I hand it off to you and anyone else who wants to speak to the group. Tell us what happened and what you think we need to do next.
So real quick, Jonathan, I have to transition to another call in 2 minutes. So just FYI.
Yeah, so I'll let Ryan go first. The only thing I wanted to say is let's not forget Liz and how they came together. Liz and Victoria and wrote the article in the EMS world, which for Alan, it will answer a lot of the issues because we do have some data. But Liz is dropped out, and we need to recognize Liz's contributions and host somehow. Hopefully, we can keep her connected. Go ahead, Ryan. Why don't you go first and give your perspective?
Yeah, absolutely. So first of all, Tony, it was a pleasure to finally meet you in person at FDIC. That was my first time going to that conference. I actually had to be in the area for other meetings and was able to kind of swing in there for a few hours, which was certainly not enough time to see everybody and get to do the things that we wanted to do. But Tony, it was really cool because he kind of set up this table, if you will, in this like little discussion area they had set up in the GEMS Lounge or the Zoll Lounge or whatever it was called that day. And it was just fascinating to get some folks together around the table to really talk about whether it was community paramedicine or just different ways that we can model mobile medicine to be more effective for the communities that we serve, and how not a one-size-fits-all approach is going to work, and that we have to have kind of customizable programs for the communities based on the specific community health needs. And that's really kind of what got the conversation kicked off. And we ended up having, I forget off the top of my head the gentleman's name now, the deputy chief from, I believe it was Fort Lauderdale Fire Department was there. We had a few others that joined us. Steve, yes. So just, again, it started off with just a couple of us at the table, and then it kind of started to grow from there just because the topics were of such interest. And it was so, such out of the box thinking for what has become traditional to this industry. And those are the real thought leaders, and those are the people that I believe are on this call and the people that we need to continue to put at the forefront of what we're doing. But again, unfortunately, I got to drop off for another call, but I'm going to turn it over to Anthony there, and you can go ahead and take it from there. But it was truly a pleasure, and we had some great conversation while I was there.
So before Ryan drops off, what we really talked about in the beginning a lot is all the magic work that Ryan is doing through Thorn Ambulance. And he really should change the name from Thorn Ambulance to Mobile Medicine or something else, innovative care, because he's just expanding. Jonathan, you just talked about part of what he's doing and the relationships he's building with different types of organizations, not just hospitals, to, as somebody else said, plug and play the right level of service for that community or for that agency to make things happen. So that really led off the conversation. The funny thing with Steve Shaw, he was actually moderating another discussion. By the way, our discussion, we were moderating about mobile integrated health. What about it? Why should you do it? What are the challenges? And it ended up only being 4 of us, but it was still a good conversation. And Ryan and I were able to connect on that easily. And Steve Shaw, who's from Fort Lauderdale, a fire department, right? And we talk about all the different organizations. We got private EMS, we've got third service EMS, municipal county EMS, and we got fire departments doing this also. And Fort Lauderdale is really moving at this point to start getting involved, because they're seeing the need and the benefit from creating that integrated healthcare that doesn't one size fits all, brings the right service to the right patient. That's my kind of new motto, bringing the right service to the right patient, and talking about what it takes to get there. And I'd like to step back a little bit, because all this talks about having the right type of leadership and the right people in place. And I just saw somebody did an article, a study of what the problems are in the fire service. I mean, in EMS, and it's people that don't have a vision for the future, that are poor leaders, that don't have good leadership, that don't have character-based leadership, and they're just out for every day, as the I think it was a Saturday Night Live thing or the commercial. We pick up things and put them down. We got to get out of that mode of that's what we do every day. We just pick up people, put them down, and we do very little in between. So part of this discussion is who's going to be in the leadership positions of these organizations. And not only do you have to be a visionary, but you have to be a good leader of your people. You got to be able to motivate, inspire, and keep them involved and get them to think above and beyond. And when you're interviewing and hiring these people, that you're hiring the right people, and you tell them, look, we're no longer going, and think about this, fire, police, EMS, the military all have the same problem. We hire people to go in and run into emergencies, yet it's only 5 to 10% what we do. So if we're going to talk about some of the challenges in mobile integrated health, is making sure that when we recruit and we interview, that we're bringing the right people into the system. And even if they're not exactly, we give them what the expectations are. So, hey, you still want to come in because you're joining the fire department, but you become a paramedic because, as in Washington, D.C., you get to go to engine 10 and fight fire, even though it's only 10% of the time. But hey, and the other 90% of the time, you better be committed to provide a mobile integrated healthcare. If not, this isn't the place for you. So talking about, the employment part and great in partnerships. And I'm sorry that Ryan had to leave, because really, he's key to actually doing this. We need to have a little bit better profile on that. And actually, the way we ended up is I've been writing an article for about 1.5 years on what is a healthy EMS culture, organizational culture. And Ryan already wrote something, and I told him we need to get together and finish that. But that's something I think collaboratively we need to do. And the final part that I'll get to, as I said already, as some of you know, we've had Larry Morrissey, who is with, I forget the name of it, somebody will think of it, the healthcare service outside of Rockford, but he was a mayor for 8 years. And through his fire chief, he learned that mobile medical care, mobile integrated health, and he started actually by trying to get every veteran, which he was successful through his fire department, mobile integrated health, getting every veteran off the street, getting them the care they need. And he realized that it was expanding more than that, and that they were in the healthcare business. And I would tell you that if you're in a fire department and you're trying to put out a fire, you're doing it because you want to save a life, or you don't want somebody injured. If you're learning how to rescue, you're doing it to take care of a person, a patient. You're doing healthcare. The police department's doing healthcare, public health. But communities don't understand that. They think EMS is what's important is who is the cheapest person that I can get that could be on scene 8 minutes and 59 seconds, right? That's what they're looking at. And we need to change that paradigm. And so, Jonathan, while I agree we need to make leaps and bounds, I think we need to get a white paper that goes to the National League of Mayors, that goes to ICMA, and anybody else that needs to hear it, of this collective from all parts of mobile medical health, of what they should be looking at, how they should be looking to provide that service, whether it's private, fire department, third service, nonprofit, what they should be looking at of how do you do that health assessment, which includes the social determinants of health. How do you do that assessment, your community health assessment? And then how do you determine how to provide the service and how you bring everybody to integrate it?